Welcome to the May 2021 in-service dedicated to the wonderful staff of the Kent Northwest Kidney Center. Today we will discuss the common problem of intradialytic hypotension. It's a very common problem. It's also a very serious problem as well with many potential complications. These include decreased dialysis efficiency, volume overload, access thrombosis, organ ischemia, and even death. So it's very important that we understand the problem of hypotension during dialysis in an effort to minimize its occurrence and treat it promptly when it happens in order to prevent serious complications. There are three objectives to today's talk. First, define intradialytic hypotension. Second, to understand risk factors and physiology behind the hypotension. And three, know treatment and prevention strategies. Intradialytic hypotension is variably defined. According to the KDOQI, or Kidney Dialysis Outcome Quality Initiative, intradialytic hypotension is defined as the presence of symptoms of low blood pressure plus a decrease in systolic blood pressure of 20 millimeters of mercury or more, or a decrease in your mean arterial pressure by more than 10 millimeters of mercury. Now, the mean arterial pressure is calculated by adding the diastolic blood pressure plus 1/3 of the pulse pressure, which is the difference between the systolic and the diastolic blood pressure. And none of us is going to sit there calculating the mean arterial pressure. So I actually don't find that clinically useful. And in almost all dialysis patients, systolic blood pressure falls by at least 20 points. So I actually don't find this to be a very useful definition. The one that most of us use is a systolic blood pressure of less than 90. You could say less than 100, but just picking an absolute number I think is easier to work with. Okay, so in the first part of the talk, we'll discuss epidemiology, so risk factors as well as the pathophysiology behind intradialytic hypotension. Intradialytic hypotension is a very common problem. It complicates anywhere from 5 to at least 30% of all dialysis treatments, depending on the definition used. In one study, it was actually present at 75% frequency, looked at 44,801 dialysis treatments in over 1,100 dialysis patients, and 75% had at least one episode of intradialytic hypotension. In some patients, more than 50% of treatments are complicated by intradialytic hypotension. So again, this is a very common problem. There are multiple demographic risk factors that have been associated with low blood pressure during the dialysis treatment. These include older age, so above the age of 65, longer dialysis vintage, so people who have been on dialysis for a long period of time, the presence of diabetes, a low pre-dialysis systolic blood pressure, a low serum albumin. Women are more likely to have low blood pressure during dialysis, a higher body mass index, and the first dialysis session of the week. So the odds of hypotension occurring actually decrease over the course of the week, with the highest one being either a Monday or Tuesday, depending on your schedule. Now, you can understand these risk factors better if you understand the physiology behind hypotension. So why does blood pressure fall during the dialysis treatment? Well, there are many causes of intradialytic hypotension, but you can boil them all down to just three categories. Rate, so the heart rate, volume, how much fluid you have inside your blood vessels, and pump, so how well the heart works. So these three words pop into my head every time I see someone with hypotension, and I hope they pop into your head in the future when you manage a hypotensive dialysis patient. The first of these is an abnormal heart rate. So how does an abnormal heart rate contribute to hypotension? Well, if the heart is pumping very fast, the heart does not have time to fill with blood. If the heart is pumping very slow, that leads to a low cardiac output. So the heart doesn't pump enough blood, resulting in low blood pressure. Volume is the second cause of low blood pressure. So specifically, is the patient volume depleted? Have we removed, say, too much fluid with dialysis or removed fluid too fast? Have the blood vessels been or lost their ability to vasoconstrict or tighten? That is, are the muscles in the blood vessel wall too relaxed? This can be caused by blood pressure medication, infection, or a nerve problem, which is called autonomic neuropathy, which we'll discuss later. And finally, is there any evidence of blood loss? So acute blood loss or hemolysis, which is rupture of the red blood cells, will lower blood pressure. And the final cause of low blood pressure is a pump problem. So this refers to any heart problem, and that can cause hypotension. It includes, say, a heart attack or myocardial infarction, fluid around the heart called a pericardial effusion, which limits the ability of the heart muscle to expand. And finally, an abnormal heart rhythm or an arrhythmia. So you can classify all the causes of hypertension according to these three categories: rate, volume, or pump. So specifically, a rapid heart rate such as atrial fibrillation can produce hypotension, or a slow heart rate, as may be seen with hyperkalemia or heart block, can cause hypotension. In the volume category, again, the most common cause is rapid or excessive fluid removal during dialysis. That could be due to an incorrect dry weight. Of course, a lot of dialysis patients, about 80%, use blood pressure medications, and these can lower blood pressure during dialysis treatment, particularly when we're removing fluid. Interestingly, eating before dialysis or during dialysis contribute to low blood because the intestines sequester more of the blood supply to help with digestion. Of course, hemorrhage, so blood loss or infection, and rarely people can have a reaction to the dialyzer, which can cause abnormal dilation of the blood vessels. And finally, under the pump category, you have things like heart failure, again, the fluid around the heart called pericardial tamponade, valvular heart disease. Now let's look at some of the specific causes of intradialytic hypotension in more detail. A rapid rate of fluid removal or rapid ultrafiltration rate is a common cause of intradialytic hypotension. Recall that ultrafiltration is the removal of fluid during the dialysis procedure. And if we remove fluid at a rapid rate, it commonly causes low blood pressure because we are removing fluid from the blood vessels faster than it can be replaced from the tissues. And this is particularly common when we are removing large amounts of fluid. An inaccurate dry weight is another common cause of low blood pressure. Even in the absence of a large fluid gain, sometimes if we remove more fluid than a patient has to give, we will cause low blood pressure. And this is generally due to inaccurate determination of the fluid status. So if we have a patient who has low blood pressure during dialysis and they have no edema on exam and clear lungs, that's a good time to contact a nephrologist for a new dry weight. A rapid reduction in the concentration of the blood, so the plasma osmolality during dialysis, can also contribute to not having enough fluid inside of the blood vessels. How does this work? Well, if you remove things like sodium and glucose and other waste products, you decrease the concentration of the blood. So you reduce the plasma osmolality. And so what that does is it causes extra water to move from the blood vessels into the cells, which decreases the amount of fluid inside of the blood vessels. So this is another common cause of hypotension, even in the absence of removing large amounts of fluid. There's another problem called autonomic dysfunction, which can also predispose a patient towards low blood pressure during the dialysis procedure. So many patients on dialysis have nerve damage or neuropathy, and this can affect nerves that control your blood pressure. We call this autonomic dysfunction, and it occurs in more than 50% of dialysis patients, particularly among those who have diabetes. Normally, when the blood pressure decreases, your sympathetic nervous system becomes activated and causes blood vessels to vasoconstrict or tighten, and causes your heart to pump harder, which increases your blood pressure. But if you have something called autonomic dysfunction, you lose the ability to mount a sympathetic nerve response to maintain your systolic blood pressure and the contractility of the heart. Heart problems are another very common cause of low blood pressure in dialysis patients. A lot of people have systolic heart failure where the heart just doesn't squeeze very well. You can have an abnormal rhythm like atrial fibrillation that can compromise the ability of the heart to pump. Uncommonly, people can get fluid around the heart. We call that pericardial tamponade. Again, it limits the ability of the heart muscle to expand and fill with blood. Valvular heart disorders, so if you have like narrowing over your heart valves like aortic stenosis, this can limit your blood pressure. If you have a myocardial infarction or a heart attack, then the heart just doesn't pump as well, and this can lead to something called ischemic heart disease, which is a very common problem among dialysis patients. So ischemic heart disease is a condition in which the heart muscle has been compromised by insufficient blood supply and oftentimes previous heart attacks. It's a highly prevalent problem in dialysis patients. Most dialysis patients die of heart disease, and frequent low blood pressure is often a sign that the heart is not getting enough blood. There was a study published by Poldermans in 1999 that looked at 18 dialysis patients who frequently had intradialytic hypotension, so low blood pressure during the dialysis treatment, and they compared them to 18 hemodialysis patients who had no problems with blood pressure during dialysis. All of these patients underwent a cardiac stress test to see how well the heart functioned under a situation of stress. And what they found was that the heart function was similar at rest between the two groups, but during stress, the dialysis patients with frequent hypotension demonstrated much worse cardiac function. So this is a good reminder that it's important to look for underlying cardiac disease in dialysis patients with frequent intradialytic hypotension. Okay, let's now shift gears and move on to the consequences of intradialytic hypotension. So low blood pressure during dialysis is often asymptomatic, but in patients who do have symptoms, they can include fatigue, malaise or basically feeling lousy, lightheadedness, muscle cramps. If your intestines don't get enough blood supply, you might have nausea and vomiting, chest pain, shortness of breath, and of course patients can pass out and have loss of consciousness. In addition to the acute symptoms associated with low blood pressure during dialysis, there are several significant consequences of this problem. These include volume overload, tissue hypoperfusion, so I'll explain that momentarily, access thrombosis, so clotting of your fistula, your graft, and increased mortality. So hypotension limits our ability to remove fluid during dialysis. This leads to an inability oftentimes to achieve dry weight and consequently causes volume overload. Patients are oftentimes given saline for their hypotension. They often then leave the treatment above their dry weight. And then they come in for the next treatment and they're even more fluid overloaded. We try to take off more fluid and the cycle of hypotension and volume overload repeats. Severe hypotension can compromise blood supply to various organs. These include the heart, and it can cause a heart attack, the brain, and it can cause a stroke, or syncope, basically means loss of consciousness. And if you don't get enough blood supply to your intestines, you can have something called ischemic bowel, or basically part of your intestines die. And this is a life-threatening condition with very high mortality. Low blood pressure during the dialysis treatment also increases the risk of clotting your dialysis fistula or graft. These are data from the HEMO study, which is a randomized controlled trial of almost 1,500 hemodialysis patients. It was published in 2002. And there was a retrospective study which looked at the risk of axis thrombosis among patients, hemodialysis patients who had frequent intradialytic hypotension. And what they found was that the risk of thrombosis was twice that among those who had hypotension in more than 30% of their dialysis treatments. Frequent intradialytic hypotension is also associated with increased mortality. This is a study published in 2013. The design was a retrospective observational cohort looking at over 6,000 in-center thrice-weekly dialysis patients in the U.S. And they found that those who had systolic blood pressure of less than 90 in 30% or more of treatments had a higher mortality. Now let's move on to the management of acute intradialytic hypotension. So when you have a hypotensive dialysis patient, you have to simultaneously think about the causes as well as work quickly to correct the problem. So remember to think about the causes. Rate volume pump. Is the heart rate fast? Is it slow? Think about volume. Was the ultrafiltration target high? Has the patient had fever, chills, shakes to suggest infection? Look at the dialyzer. Is there any evidence of hemolysis? And finally, pump. Does this patient have known heart failure? Are they having chest pain? So all of these questions have to pop into your mind while you're managing the patient. Regarding management, first step is to stop ultrafiltration. Administer a fluid bolus, provide supplemental oxygen, and we often consider something called Trendelenburg or head down position. So how is Trendelenburg done? Well, the head is tilted down, basically the feet and legs are above the level of the heart. Kind of the idea is to divert blood from the lower extremities into the central circulation, which ideally would improve cardiac filling and the central blood volume. The problem is that the Trendelenburg position is a good example of an intervention that's based on tradition rather than scientific evidence. In fact, most studies show that it doesn't significantly improve systolic blood pressure or cardiac output. One of those studies was published by Bivens in 1985, looked at 10 normotensive dialysis patients, and tagged red blood cells were used to quantify blood volume distribution. What they found was that the use of Trendelenburg increased blood volume only by about 1.8%, so 98 milliliters into the upper compartment, and there was no significant hemodynamic or clinical benefit that was observed. There are some potential downsides to the Trendelenburg position. For starters, you can decrease your oxygen saturations probably because of the intra-abdominal pressure that shifts up and presses up against the diaphragm, which squeezes your lungs. The abdominal contents also can compress the vein, the main vein called the vena cava, which puts pressure on the baroreceptors, which blocks the increased sympathetic response to low blood pressure. And finally, it's really not well tolerated in alert patients. People don't like to be on their head. So when to send a patient to the emergency room? Well, essentially, if their blood pressure doesn't respond to a fluid bolus, or if you're concerned that there is some other cause besides removing too much fluid, such as infection. So if they have fever, chills, or rigors, if they have chest pain, which might raise your suspicion for a myocardial infarction, or some other problem like an aortic dissection. And finally, if they have abdominal pain, we'd really worry about intestinal ischemia. Again, the intestine's not getting as much blood supply. So if they have any reason for hypotension other than, excessive ultrafiltration that fails to respond to saline administration, we would send them to the ER. So how can we prevent intradialytic hypotension? Step one is to reassess their dry weight. So again, if they have no edema on exam, lungs are clear, the dry weight might be too low, and the nephrologist should be contacted. Avoid eating during dialysis. Of course, we don't do this during the COVID pandemic anyway, but again, eating shunts blood away from the central circulation to the digestive organs, and that can reduce your blood pressure. Of course, we've got to look at their medicines. If someone has frequent intradialytic hypotension, then it would be wise to hold their blood pressure medications before dialysis. Of course, we have to encourage patients to limit fluid gains, avoid salt, control your sugar. These things will make you thirsty and make you drink more. The more fluid people gain, the more fluid we have to take off, and the more likely intradialytic hypotension will occur. And finally, we always have to consider the good recommendation of reducing the ultrafiltration rate. People may have 3 or 4 kilos that they have to remove, but sometimes they just need an extra suffron or a longer dialysis duration. For patients who have frequent low blood pressure during dialysis, despite the above intervention, you can consider cooling the dialysate. So the typical dialysate temperature is 37 degrees. You can consider reducing it to, say, 35.5 or 36 degrees. What does this do? Well, if you are cool, it causes your blood vessels to tighten up or vasoconstrict, and this increases your blood pressure. It is an intervention recommended by the 2005 KDOQI guidelines, as well as the 2007 European Best Practice Guidelines. So how does cooling dialysate work? Well, it increases your systemic vascular resistance. That is, again, it causes your blood vessels to tighten up. It also increases the contractility of the heart. And some of these changes are probably in part at least mediated by activation of the sympathetic nervous system. In the last decade, there have been a couple of large meta-analyses looking at the impact of cooling dialysate on hemodynamic stability. This is one of the meta-analyses published by Mustafa in 2016. It was a meta-analysis, again, of multiple pooled studies, which included 26 trials, total of 484 dialysis patients. And in 11 of these, there was enough information to allow calculation of the pooled effect of cooling dialysate on low blood pressure. What they found was that compared with standard dialysis, cooling the dialysate temperature reduced the risk of intradialytic hypotension by 68%. So it's a very big impact. Of course, it came at the price of making people feel cold. So people felt cold, shivered, or had cramps about 3 times more often with the cool temperature dialysate compared with standard temperature. But cool temperature dialysate did not appear to impact adequacy negatively or overall quality of life. So in general, it was pretty well tolerated by the patients in this study. So what's the downside to dialysate cooling aside from making people feel cold? Well, there is concern for a reduction in adequacy. In other words, how well we clean the blood. When you cool dialysate, again, it causes vasoconstriction of the arteries, which supply the tissues, such as your muscle, and therefore less blood circulates through these tissues during dialysis. On the plus side, no studies in the 2 large meta-analyses that have been published reported that cooled dialysate led to a reduction in adequacy by urea clearance. And also, there are no trials available that examine the long-term effects of cooling dialysate on patient outcomes, such as hospitalization or mortality. Another treatment option for patients with frequent intradialytic hypotension is medication called midodrine. Midodrine is an alpha-1 adrenergic agonist that causes vasoconstriction of blood vessels, which increases pressure. It's usually given 10 to 30 minutes prior to a dialysis treatment. You can even give it halfway through a dialysis treatment. Studies have shown that midodrine improves chronic hypotension in dialysis patients by essentially modulating the autonomic function in its direct effects on peripheral vessels. So it essentially causes vasoconstriction of the blood vessels. Midodrine has been looked at in several studies, including this meta-analysis published by Prakash in 2004. This was a meta-analysis or a pooled study of 10 Canadian studies, and what they found was that midodrine use was associated with increasing the post-dialysis systolic and diastolic blood pressure by about 10 millimeters of mercury. So it prevented or it raised the systolic blood pressure by about 13 points at its nadir and diastolic by about 6 blood pressure millimeters of mercury at its nadir as well, compared to controls. But the use of midodrine is not without risk. This is a retrospective study published by Brunelli in 2018 that compared clinical and hemodynamic outcomes among dialysis patients who were prescribed midodrine and matched controls who did not receive it. And what they found was that midodrine use was associated actually with higher rates of death, so 37% higher rate of death, as well as all-cause more hospitalization and cardiovascular hospitalization. Midodrine use was actually associated with lower pre-diastolic blood pressure, greater fall in systolic blood pressure, and a greater proportion of treatments affected by intradialytic hypotension. The problem is, of course, this is an observational study, so you're unable to establish causation. That is, um, uh, you're unable to say that the midodrine resulted in more frequent hospitalization or death, or if maybe just the patients who received midodrine were sicker and had more hypotension and therefore were more likely to do poorly. We are almost at the conclusion of this talk, so hang in there just a little bit longer. Other options include increasing dialysis time, which allows for a slower rate of fluid removal, or changing dialysis modalities. So peritoneal dialysis and home hemodialysis just allow for more frequent dialysis and therefore less fluid removal with each treatment, which is generally better tolerated. In summary, hypotension is common during dialysis. It compromises organ perfusion, increases risk of access thrombosis, increases mortality rate. When you evaluate a patient for hypotension, think rate, volume, or pump. How do we minimize hypertension? Well, we adjust their dry weight. We hold antihypertensive before dialysis. We have to treat patients promptly. We take hypertension very seriously. We assess for a cause. We give saline. We slow the ultrafiltration rate. Trendelenburg is probably not useful. In our patients who are chronically hypotensive, consider midodrine and cooling the dialysate. All right, time for the obligatory quiz. How often does intradialytic hypotension occur? That's right, about 30%. Of course, there's a big range, anywhere from 10 to 70%, but most people remember 30%. Next question, true or false? Intradialytic hypotension is associated with increased morbidity and mortality. That's right, it's true. Next question. Name 3 causes of intradialytic hypotension. So this is the easy one because there are so many. But broadly, think about rate, volume, or pump. Again, rapid heart rate, slow heart rate, excess ultrafiltration, blood pressure medications, eating on dialysis, hemorrhage, or heart failure, valvular heart disease, etc. So when you think of someone who has hypotension, think rate, volume, or pump. Okay, what are common interventions you can recommend to your patients to minimize intradialytic hypotension. Excellent. So minimize fluid gain. So make sure patients don't drink too much between their treatments. Avoid taking blood pressure medications prior to dialysis. Avoid eating before or during dialysis. Last question. What are measures a nephrologist can prescribe to minimize intradialytic hypotension? Yep, you can cool dialysate, and a nephrologist can prescribe midodrine. Also consider changing dialysis modality. This concludes the May in-service for the Kent Northwest Kidney Center. Thank you to the staff of the Northwest Kidney Center for all of your excellent care of our patients. This is Andy Brokenborough signing out.